In this lecture, we will discuss short QT syndrome, including its prevalence, pathophysiology, EKG features, as well as proposed diagnostic criteria and treatment. Subtle differences in the QRS, ST, or T-wave morphologies generally represent benign variations. However, in some cases, these changes may be diagnostic clues to identify rare inherited disorders that are associated with an increased risk of sudden cardiac death. These inherited disorders can have unique underlying mechanisms and presentations, but there are a few characteristics that they share. These characteristics include an increased risk of sudden cardiac death. They are the result of functional mutations in ion channels, ion channel accessory proteins, or myocardial structural genes. They are also mostly appear in people that have absence or no overt structural heart disease. And lastly, they have characteristic EKG patterns. And it's this characteristic EKG patterns that help to differentiate these inherited arrhythmia disorders. Now, in this lecture, we're going to focus on short QT syndrome. So short QT syndrome is a relatively new disease that was first described in 2000. It is only in recent years that we've been able to elucidate some of the genetic, clinical, and electrophysiological abnormalities of the disease. Now, short QT syndrome is much less common than long QT syndrome. In fact, there are less than 100 cases ever reported to date, and the true prevalence remains unknown. Patients are typically young and healthy without structural heart disease. They can present as early as a few months of age to the 6th decade of life, with a median age of about 30 years. The most common initial presenting symptom is cardiac arrest, while others may experience palpitations or syncope due to rapid atrial fibrillation or self-terminating ventricular arrhythmias. So as we've alluded to, short QT syndrome is an arrhythmogenic disease associated with paroxysmal atrial and ventricular fibrillation, syncope, and sudden cardiac death. But what is the mechanism for this arrhythmogenic effect? Well, this arrhythmogenesis is thought to result from two things. One being extremely short atrial and ventricular refractory periods, which manifest as a short QT interval, as well as the second one, which is transmural dispersion of repolarization, which means that there's different layers of the myocardium, including the endocardium, the mid-myocardial M cells, and the epicardium that are repolarizing at different rates. And it's believed that these repolarization abnormalities carry an increased susceptibility to reentrant atrial and ventricular arrhythmias. All right, so just to recap, with short QT syndrome, like with long QT syndrome, there is abnormal myocardial repolarization. However, with short QT syndrome, this abnormal repolarization is occurring at various rates within the heart and is rapid, which shortens that QT interval and increases the risk of fatal ventricular arrhythmias. Hopefully that makes sense. Now, short QT syndrome can either be inherited or acquired. Our focus is on the inherited form, but we'll also mention some of the acquired causes. So if it is inherited, it tends to be the result of an ion-associated gene mutation. And these genes involved are important in the repolarization phase of the cardiac action potential. And it seems like there are 5 main genes involved. 3 of these genes, the KCNH2, KCNQ1, and KCNJ2, have been considered to be associated with short QT syndrome genotypes 1, 2, and 3, respectively. These genes encode for voltage-gated potassium channels and undergo gain-of-function mutations that increase the potassium efflux during the repolarization phase, and consequently shorten the action potential and QT interval. This is opposite to what we saw in long QT syndrome. Now, there are also 2 other genotypes that we should mention, genotypes 4 and 5. These are the result of a loss of function mutation in the L-type cardiac channel, okay, that calcium channel, with reduced influx of calcium during the plateau phase of the action potential, leading to a more modest shortening of the QT interval, often less than 360 milliseconds. And this is associated with a Brugada syndrome-like QRS complex morphology. So that's a quick overview of the inherited forms. We also mentioned there's some acquired cases, and some of these potential causes include hyperthermia, acidosis, hyperkalemia, hypercalcemia, and changes in autonomic tone. All right, so let's finally move on to the EKG features. So first off, as you would expect, a short QTC interval is the hallmark of the disorder. In general, a short QTC interval can be considered anything less than 360 milliseconds. However, there are many normal patients with a short QTC interval of less than 360 milliseconds. So when should you really start to consider short QT syndrome is when you have a QTC interval that's less than 330 milliseconds in males and less than 340 milliseconds in females, okay? So finally, we're down here at our EKG features, and we're saying the hallmark is this short QTC interval, and we said that here's our, remember, our QT interval is from the beginning of our QRS complex to the end of our T wave, okay? This is our T wave, and this is our QRS complex, okay? So we have a short QT interval, and you can see that here. Remember, from one thick line to the next thick line, so from here to here, that represents 200 milliseconds. So if we go to this point here, okay, we're just about at 240 milliseconds. And we said it's short if it's less than 360 milliseconds, but more specifically in short QT syndrome, we want males to have a QT interval that's less than 300 milliseconds, okay, so this is the males, and then we want the females to have one that is less than 340 milliseconds, okay, so the females a little longer, but we want both of them in that range, okay? So you can see there's some gender differences here that are already evident. Now, it's important to note that there is currently no universally accepted lower limit of normal for the QT interval that can be used to diagnose short QT syndrome. Known patients with short QT syndrome genotypes 1 through 3 have shown to have a shorter QTC intervals than those with genotypes 4 and 5. Now, regardless of the genotype, nearly all have been shown to have a QT interval of less than 320 milliseconds and a QTC interval less than 340 milliseconds. Okay. Now, another clue for short QT syndrome is that patients tend to demonstrate fixed QT intervals over a range of heart rates. In other words, they lack normal QT interval changes with heart rate. For example, at fast heart rates, the QTC interval may appear normal. However, if the heart rate slows, the QTC interval fails to prolong. Okay, remember, we use that QTC interval to correct for heart rate, but with these patients you don't tend to have those changes, and they lack that normal QT interval changes with the changes in heart rate. So some other EKG features to be aware of have to do with the ST segment in the T-wave morphology. Typically, there is a short or absent ST segment with a T-wave beginning immediately after the S-wave, and the T-wave is usually peaked and narrow, especially in the precordial leads. Now, if you look at up different types, you may see variations in the T-wave morphology, but for this one, this is a good example of the short QT syndrome type 1, okay? And that's this one here, where we see an absent or short ST segment, okay? So we have a short ST segment here, okay? Sometimes it's pretty much absent. And then we have these peaked narrow QRS, or T waves, okay? So peaked and narrow T waves, as you can see in this case here, okay? So an absent or short ST segment, as you can see here, in these peaked narrow T waves, especially in those precordial leads, they tend to be the most evident. Now, a final point with EKG is that because short QT syndrome is arrhythmogenic, we may see episodes of atrial fibrillation or ventricular fibrillation. So let's conclude this lecture with the diagnosis and treatment. Now, first off, when making the diagnosis of short QT syndrome, it's important to keep in mind that a short QTC interval alone is not sufficient to make the diagnosis. There must be an increased risk of sudden cardiac death. In order to assist with the diagnosis of short QT syndrome, diagnostic criteria has been proposed with a point system that can give you an idea of how likely short QT syndrome is present in a patient. We'll briefly look at that system now. So if you look here, remember with long QT syndrome, we looked at the short score, and this is one that you can have for the short QT syndrome. Again, it's looking here at the EKG findings. It's looking at the clinical history. It's looking at the family history, and then we can also have the genotype. And remember, this is a score or point system. Okay, so at the end, we'll add up these points, and from that, you can find out the probability of whether or not the patient is at risk or likely has short QT syndrome. So with the EKG features, you're first looking at the QTC interval. Okay, QTC, the corrected QT interval for heart rate, and you're using the Bazet formula, and if you recall, that's the QTC equals the QT interval over the square root of the R to R interval. If it's less than 370 milliseconds, 1 point is given. If it's less than 350 milliseconds, 2 points. And if it's less than 330 milliseconds, it makes it more likely, so you get more points, you get 3 points, okay? So already if you get 3 points, you're at an intermediate probability, okay? And just need 1 more point to reach that high probability of short QT syndrome. Another thing to look at is the J point T peak interval, okay? And this you want to be less than 120 milliseconds. And you want to measure this in the precordial lead with the greatest T wave amplitude, okay? So what you're doing here is you're taking the J point. So let me just erase this here so you can see the J point is at the end. Marks the beginning of the ST segment. It's the end of our QRS complex. So imagine this is our J point here, and we're marking or looking at the duration from that point to the peak of our T wave, okay? And if it's less than 120 milliseconds, which is 3 small boxes, you get 1 point for that, okay? Now to the clinical history, and in this case, you have to make sure that there's no identifiable cause that is resulting in this, okay? So make sure that you don't have any other thing that's contributing to this. So if the patient has AFib, make sure that there's nothing else that's contributing to the AFib, okay? So if the patient had AFib, you get 1 point. If it's unexplained syncope, 1 point. And then with these two, you get 2 points. The history of sudden cardiac arrest, again, not due to any identifiable cause, as well as documented polymorphic ventricular tachycardia or ventricular fibrillation also gets 2 points. Now, we're here at the family history. And in this case, if you have a first or second degree relative with a high probability of short QT syndrome, you get 2 points, okay? So already 2 points. If you had this 330 milliseconds one or below that, you'd see you're already at high with that family history. If you have a first or second degree relative with an autopsy negative sudden cardiac death, you get 1 point, okay? And then if you have a family history of an infant that experienced SIDS, which is sudden infant death syndrome, okay? In that case, you can get 1 point for that. And in terms of the genotype, that's that fourth category. If they're genotype positive, so one of the genes that we mentioned previously, you get 2 points, okay? And if there's a mutation of undetermined significance in a culprit gene, then you also get 1 point, okay? And again, you take those points up, you add them up, and whatever you get, it'll give you either a low, high, or intermediate probability, okay? So that's that final score that you get. Now remember to keep in mind that a score greater than or equal to 4 makes the diagnosis of short QT syndrome more likely, but is not diagnostic. Now, one other simplified approach for making the diagnosis that has been suggested is that if the QTC intervals are less than 330 milliseconds in males or less than 340 milliseconds in females, it should be considered diagnostic for short QT syndrome, okay? What we're saying here is some have proposed as long as you meet this criteria here, then that it should be diagnostic in itself. Now, they also say if the QTC intervals are less than 360 milliseconds in males or less than 370 milliseconds in females, it should be considered diagnostic only when supported by clinical symptoms or family history. So that's more of a simplified approach. So just a few final points on treatment. Currently, the only effective treatment is implantation of an ICD. The main issue here is T-wave oversensing and inappropriate shocks due to tall, narrow T-waves. Potassium blocking antiarrhythmic agents have also been tried. Class 3 agents have been shown to be ineffective due to reduced drug binding to mutated potassium channels, although Class 1A agents have been shown to be more promising. Quinidine is currently the drug of choice in such cases and has been shown in short QT syndrome type 1 to prolong both the QT interval and ventricular refractory period with normalization of the ST segments in T waves, as well as preventing ventricular fibrillation induction. All right, so that was a lot. Let's review what we discussed before we end here. So again, short QT syndrome is when you have abnormally rapid repolarization. That gives you that short QT interval. And remember, you're having this occur, those repolarization occurring at various rates, and that all this combined leads to an increased risk of these fatal arrhythmias. Okay, we mentioned the things that inherited arrhythmia disorders have in common. Okay, the main distinguishing one was the EKG features that we talked about down here. Now remember the mechanism in this case, we have the short atrial and ventricular refractory period on top of the transmural dispersion of repolarization, meaning that you have repolarization happening at different rates at different myocardial layers. Okay, and with that all leads to an increased risk of arrhythmia. Okay, and we said it can be inherited or acquired. The main feature we're looking at here is the inherited form, and in this case you have these ion-associated gene mutations. Okay, we saw this KCNH2 is the genotype 1, short QT syndrome type 1, okay, related with the potassium channel. Same thing with this type 2 is also a potassium channel, and type 3 is also a potassium channel. 4 and 5 are ones that have a little greater QT intervals, but have more to do with the calcium channels. Okay, and then we mentioned a number of acquired causes: the hyperthermia, acidosis, hyperkalemia, hypercalcemia, and autonomic tone changes. And with the EKG features, okay, we mentioned the short QTC interval, less than 330 milliseconds in males and less than 340 milliseconds in females, was that characteristic and pretty much the hallmark of the syndrome. Okay. And then remember, all cases so far have had a QT interval less than 320 milliseconds and a QTC interval less than 340 milliseconds. So those are good cutoffs to use. Again, remember these patients tend to lack normal QT interval changes with heart rate. You tend to see these peaked and narrow T waves as we saw here, especially in those precordial leads. You'll have a short or absent ST segments, as well as possibly these episodic atrial fibrillation and ventricular fibrillation coming on and off in these patients. Okay, and then we went through this scoring system, this point system that gives you the likelihood of making the diagnosis of short QT syndrome. Okay, and you can go through that. Remember, we looked at EKG features, factoring clinical history, family history, as well as genotype. Well, that's the end of this lecture. We discussed short QT syndrome, including its prevalence, pathophysiology, EKG features, as well as proposed diagnostic criteria and treatment. I hope you learned something.